Can you please sit down, because we're going to start in a few seconds. It reminds me of teaching medical students. Okay, I'm just going to say what is going to happen next very briefly. We're going to hear from Professor Bob Wachter, and about 6 o'clock we'll have a few closing remarks, and then for those who are able to join us, we're going to have drinks, which is, there'll be people outside standing, but basically you're going to turn left outside and go across the bridge, and there's wine and chance to talk more and ask to meet the speakers and so on. So please do come and have a drink, even if it's for a short time. And now it's just my great pleasure to ask Sir Liam Donaldson. It's wonderful to have Liam here to introduce Bob. And just to say, as you know, that Liam has gone probably more than anyone else in the world for patient safety in one way or another. So Liam, thank you.
Thank you very Thank you very much, Charles. And I had the very great pleasure of visiting our guest lecturer tonight in his base in San Francisco about 5 years ago. I was Chief Medical Officer at the time, but actually the visit was a World Health Organization visit. So we were going to find out what Robert was doing. I hadn't met him before, but we'd heard that he was one of the foremost younger leaders in patient safety in the US. And so we had a really great visit. And given that I do a lot of traveling, often memories are warm but rather vague. But in the case of my visit to San Francisco, I have a highly detailed memory of what happened there. And the three things in particular I remember. The first is that we saw some really good projects on patient safety. Robert introduced us to a lot of very talented people in his hospital and in his university. One in particular really struck me because it sort of opened my eyes really to why sometimes we don't achieve change in patient safety. And it was actually quite a small piece of work, but very important, looking at retained instruments and needles. And what really struck me very forcibly about it was that the team who were working on it had spent 6 months looking at it in depth at all sorts of aspects of it. They'd got pigs' carcasses that they were burying needles in. They were looking at radiographs. They were looking at the density of radiographs. They were testing junior radiologists in their ability to spot needles and swabs. And remarkably, it's no great surprise that retained instruments and swabs are often survive checking procedures, or at least did in the pre-checklist days, but also that even though something was present on an X-ray, it didn't necessarily get spotted. And it struck me that in order to achieve real change in some areas, not all areas of safety, you have actually got to understand the problem in real depth, and that can sometimes mean spending months and bringing all sorts of disciplines into play to do that. So the first thing I was very impressed with was the quality of the research and the investigation and the programs that Robert and his team had in patient safety. The second thing was that I met a group of doctors in training, and as many of you know, Robert is described as the father or the creator, really, of the hospitalist scheme, which was a highly innovative education training program to create a new cadre of doctors, filling a very big gap in the US healthcare system. And he did that. It was his idea. And I met a group of them, and he withdrew tactfully, and so they could tell me the truth. And they were immensely proud, I think, to be associated as pioneers and guinea pigs in this new program, but also expressed huge admiration for Robert's leadership. And then the final memory I had, it was actually the week that one of his books was being published. I think it was Internal Bleeding was, yeah, and it was rising up the Amazon charts, and he gave me a signed copy, and I read it, most of it, on the plane going back, and it was really a brilliant synthesis of the concepts and the principles of patient safety, but in a way that unpacked them so accessibly for a lay audience, as well as a huge number of lovely examples of patient stories, but also stories of professional practice. So I came away with the impression of a man who was a scholar, who was a brilliant communicator, but above all, who was one of the most impressive, compassionate leaders that I've ever met. And so it's a real pleasure and honor for me to introduce him tonight, and we look forward enormously to hearing what you've got to say, Robert.
Thank you, Liam. That was remarkable. I really appreciate it. Really, Liam and Charles are two of my heroes in the field of patient safety, so this is a great joy and an honor to be here, and thank all of you for being here as well. I am extraordinarily impressed with what I've heard in this conference. It's the work that's being done in the center is absolutely extraordinary. I'm also impressed, Allison, I don't know where Allison is, but we were both at a conference in Switzerland 3 days ago that ran about an hour late. And here's a conference in the UK that's running on time to the moment. It's defying all of my stereotypes about national punctuality. As some of you know, I spent 6 months here in 2011 on sabbatical as a Fulbright scholar. I called Charles completely out of the blue. We'd never met, and said I'd like to come to the UK, and could I hang out in your world for 6 months? And he could not have been more gracious, and there are a number of you around who I had the chance to meet during my time here, and people were unbelievably nice and open and forthcoming and talking about the things that are wonderful about your system and about the flaws as well, and I'm immensely grateful for that. When I decided to come to Europe, there was no question that I wanted to work with Charles, that he personally and the group that he's put together is internationally known for the quality of the work that they've done. And I certainly, as I look at it and with my America-centric point of view, I would place the center really among probably the top 3 research groups in the world. I think the group at Johns Hopkins, the group at Harvard are also quite good. But the contribution of the group here is absolutely remarkable and extraordinarily broad. And I think part of that flavor came through this morning. It's not just medication errors, and it's not just design, and it's not just IT, and it's not just culture. It's all of that, and I think that breadth really is a tribute to Charles's breadth of thinking and his leadership. So it's been really a great joy to be associated with the center, and the chance to come back and speak with you is a pleasure. Let me just point out from the beginning, I'm going to give somewhat of an American perspective on this, and I'm hearkening to Martin's words about the regulator being a respectful friend. So that's what I hope I am here. I'll have a couple of comments that I think are somewhat critical of the system here. I do that fully recognizing that you spend a little bit more than half of what we spend on healthcare. Your outcomes are every bit as good, and you somehow manage to insure everyone. And so it would be perfectly reasonable for you to listen to what I say and say, what is he talking about, having anything critical to say about our system. But I think in many ways, as Martin was saying, I think coming at it from different perspectives, whether it's from a different country or from a different profession, I think adds some real value. And it's very important to take advantage of that perspective while also saying, yes, but. It's different. Aviation is different. The American healthcare system is different. But I do think there are times that the outsider can make observations that the insiders are not able to do. Just before I start, I will point out one huge difference. I was talking to Mary Dixon Woods about this during the break. It seems like every time I'm here, there is some spasmodic national crisis in healthcare. And I can I can say with quite a high level of assuredness that your system is no more likely to produce a kind of crisis than ours is. But I think the way your system reacts to it, with kind of national spasm, sort of the iconic case, the white paper, the new regulatory framework to deal with that crisis, is different than the American system. And we were scratching our heads about why that is. I think part of it is that you actually do have a system, and we don't. So there is sort of the capacity, there's enough central control when there's a crisis that breaks out for that central entity to say, oh my God, my hair's on fire, react to it, and try to fix it, sometimes improving things and sometimes unanticipated consequences, which of course will always be the case. So I think that's part of it. I think part of it is scale. When I was here, I realized that the gross national product of England is the same as the gross state product of my state of California. And so I began to think, as I thought about sort of the reaction to things in the healthcare system, I changed my frame to think, how would this happen in California, which really is about the right scale. So the ability of a single case to become a national phenomenon, in part because there's really one national media, those sort of things, I think is greater here than it is in the States. I can't really think of an example where a single case led to sort of this iconic national crisis. Maybe the Duke transplant era about 10 years ago, where we killed a young woman with a heart-lung blood transplant of the wrong blood type. Believe me, we are capable of huge national crises. If you look at the National Security Agency today, or Watergate, or we know how to do that. We just don't do it in healthcare very much. And I think that is a pretty fundamental difference between our two systems. So, and I'll get back to that a little bit later, because I think it does reflect this issue of this single system and its propensity toward centralized management and a little bit of top-downness, which I think carries some benefits but also some costs as well. So with that, let me go ahead and get started. I recognize also that although we're vaguely speaking the same language, I am an American, so I speak with this either funny accent, or you speak with this funny accent. And any time anyone comes from a different place and a different culture and different language, there's always the opportunity for confusion. I don't know if I was asking Charles if he had seen this before, and he said that he hadn't. This has become sort of a funny story in the States. This is a sign from Wales. And in Wales, as you know, I'm sure better than I do, they're trying very hard to hold on to their native language of Welsh. And so when a sign goes up, it's like in Quebec in Canada, the sign must be translated into Welsh as their attempt to try to keep the language alive. And of course, not many people speak Welsh, and so they have very helpfully created a website and an email where you can email in your English, and they will email back your Welsh translation. So these folks who were putting up this sign, no entry for heavy goods vehicles, residential site only, emailed into this site with this English, and they very quickly got back an email, a translation in Welsh, an email, and they, of course, put it up on the sign. And I don't know how many of you speak Welsh, but there you have it. It was only a little while later that they realized that that actually says, I'm not in the office at the moment, please send any work to be translated. So whenever we speak different languages or come from different cultures, there is this challenge where we can get a little confused and not quite get it right. So I hope we'll do a little bit better than that. So I named this talk Successes, Failures, Surprises, and Epiphanies in Patient Safety. And I thought the most useful thing I could do would be talk about my own observations about the things I've learned in patient safety over the last 12 or 13 years, some of which was from my time here in the UK. And these are really big general lessons. Leon was incredibly charitable about what I do for a living. As I think about it these days, it's really kind of advanced punditry. It's what happens in the US. You probably know you go to a liberal arts college before you go to medical school. So I was a political science major in college and then became a physician. And what I do for a living really is some kind of combination of thinking about the system and how it's organized or not organized, and trying to understand why it is the way it is and how hopefully it can work better. So these are the areas that I'm going to touch on, and I go fairly quickly to leave some time for discussion. The pace of change, and this will be a very American viewpoint, but I want to give you a sense of how extraordinarily rapidly the American system has changed to create a focus on safety and quality. There have been some parallel changes in the UK, but it's had a different flavor because of the way your system is organized. I'm going to talk a little bit about motivation and what we've learned in motivation. A lot of this comes from behavioral economics, top down and bottom up, and also the importance of extrinsic versus intrinsic rewards. And I know we have economists here. I think Peter's here and others. So I'm not a card-carrying economist. I'll probably get some of this wrong, but these are some of the things that I've learned. I'm going to talk about information technology. It was seen as the great savior in patient safety, not only in medication errors, but in much of the rest that we were doing. And I think we've all come to learn that it's harder than it looks in many ways. I'm going to talk briefly about the importance of culture, and then just one last second on how we all deal with change. So let me start at the beginning. And the beginning of the safety field in the US really was this report to Errors Human by the Institute of Medicine. It came out in December 1999, and Liam's report, An Organization with a Memory, I think had much the same flavor. A very large report by a respected national body with very respected national leaders, basically a call to arms, a burning platform saying this is a terrible problem, we need to address it, and we have not been addressing it. In the US, this was the report that had that effect. And the way it did it was, I think, very interesting and holds some lessons for generating change and passion. This is Martin talked about the number of deaths in the UK from medical errors. I guess we could call them medical mishaps. Was that the old term, Charles? So medical errors or mishaps. And again, you get a sense of the difference in scale. I think you said 3,000, 4,000 in the US. The best estimates were 44,000 to 98,000 deaths per year from medical mistakes. And this would have gotten headlines for a day or two and then moved on. We would have moved on to the next crisis. But for the best analogy, and I think the best bit of spin I've seen in my career in healthcare, this was the first time we heard that translation into the now famous jumbo jet units. Because when you do it in the States, I think you 5 to 7 planes a year. If you do it in the States with our scale, this would be a large plane crashing every single day. And that metaphor, which was used quite boldly and openly by the Institute of Medicine, really was what launched the patient safety movement. It was what was necessary to get people's attention, and all the things we've already talked about, that, who would ever fly electively if you knew a plane would crash somewhere in the country that day? What would we be doing as a system if a plane was crashing every day? We certainly would shut the system down until we fixed it. I think that was the analogy that got our patient safety movement started. And I think at the time, and here just to show you what time that was, Clinton handing over to Bush, for which I apologize. Although I have to say, when I came here 2 years ago, or 2.5 years ago, and began my sabbatical, the most common question I got as an American moving to the UK for a while, the most common question by far was, can you explain Sarah Palin to us? And my answer was no. So, but anyway, here we are. In December '99, the IOM report comes out. And I think the state of affairs at the time was most people thought quality and safety were pretty good. So this was a big surprise that it was this dangerous. In the US, we talk a lot about the business case to do things, in part because we're kind of overtly capitalist, and our system is this sort of chaotic system that is less centrally determined and regulated than yours is. And so at the time, there was absolutely no business case to improve quality and safety. If you were a CEO of a hospital system, what you call a trust, and you said, I've got $5 million left over at the end of the year, I can either advertise or build a new operating room or build a new intensive care unit or recruit a neurosurgeon, or I can invest it in computerization, teamwork training, whatever your simulation, whatever your favorite safety or quality fix is, you were not making an irrational decision not investing it in safety and quality. You can argue about whether you're making an ethical decision, but there was no business case to do that. The best hospital and the worst hospital got paid the same. There was no public reporting. In part because of both those things, nobody really knew how to do safety and quality work. And I think there was really relatively little concerted effort by healthcare leaders, clinicians, really anyone, to improve quality and safety. Now that situation has changed. I'll periodically talk to the medical students at my institution and say, folks, you are going into a different career than I went into. In your career, there will be immense pressure to figure out ways to deliver the highest quality, safest, most satisfying care at the lowest cost. And they'll look at me and say, what were you people trying to do? I mean, it seems so logical that that should be the goal, and yet that was not the goal. We were all trying to do the best we could, but it's an overarching framework for what the system was about. That was not the goal at the time. So I want to briefly take you on a 12 or 13-year tour of health policy in the United States as it pertains to safety and quality. And the goal really is to show you how much activity we have created in a system that is not very centrally managed. I think it is in many ways much more atomized, much more pluralistic. In some ways, there are some advantages to that and some detriments, but it is what it is. In order for our system to be driven to push toward safety and quality, we needed to be hit from a whole bunch of different angles. So let me just tell you what those were. I mentioned Terror's Human came out in December 1999. About a year and a half later, the same organization, the Institute of Medicine, came out with another report called Crossing the Quality Chasm. This really launched a parallel movement for healthcare quality. In 2002, an organization called the National Quality Forum, which was only 3 years old at the time, came out with a list. The list was developed by the founding chair of that organization, Ken Kaiser, and he said, here are 8 or 9 things that should never happen in healthcare. You know, like this one, a patient rather inconveniently having a surgical retractor left in his or her chest. That's something you don't want to have happen. Operating on the wrong patient, cutting on the wrong limb, those sort of things. That, of course, the shorthand became the never events list. That list has grown to about 30 items and really became the scaffolding for a group of other policy maneuvers that depended on having a list. So 5 years later, Medicare, our huge national payer, said, okay, we're not going to pay hospitals for things on that list. Up to that point, if you sent Medicare a bill to go and reoperate on this poor patient, Medicare would have paid you to do that. They said, we're not going to do that anymore. Many things on that list now are publicly reported. So the list was important, not so much in and of itself, but because it became a vehicle for other policy maneuvers around a list of serious bad things that were felt to be largely preventable. This is Beth McGlynn, a very accomplished healthcare researcher, now working for Kaiser Permanente, one of the big healthcare delivery systems. At the time, in 2003, she worked for the RAND Corporation. And she looked at a little over 100 practices where the evidence was crystal clear what the right thing to do was, whether it was treatment of high blood pressure or treatment of sepsis or vaccinations. And she found in American healthcare, when the evidence was crystal clear, we did that thing 54% of the time. Those of you who are Six Sigma fans, that's about like 1 sigma or half a sigma. There's no industry that I know of that would stay in business if they got it right 54% of the time. Think about how long Federal Express would stay in business if they got you your package 54% of the time. But that is, in fact, our degree of reliability in American healthcare circa 2003. The Joint Commission is the main accreditor of American hospitals. This is hospitals voluntarily agree to be inspected by the Joint Commission. In 2004, in part because of the pressures they were feeling because of the IOM report, the Joint Commission changed their inspection process. Up until 2004, hospitals had about 2 years' notice of the day they were going to be inspected. And it sounds funny, but it was true. In my hospital, we knew the day they were coming. The floors were waxed beautifully. The medications were all locked up in lockers. By far the most dangerous day of the year in my hospital. The floors were slippery as hell. No one could find any of the medications because they weren't where they usually were. In 2004, the Joint Commission changed their process. My hospital and every hospital in the country that's now accredited by the Joint Commission now has 30 minutes notice of a Joint Commission inspection. That's someone's job in my hospital to go on their website Monday mornings at 7 in the morning to see whether they'll be in our lobby at 7:30. Of course, if you were a patient and you believed this was a useful process, that is what you would want. It's ridiculous to believe that the hospital should have a year to get ready for a safety inspection. In 2004, 2005, Medicare, again the large federal payer, began publicly reporting hospital data. It began with simple process data. Patients with pneumonia, did they get the correct antibiotics? Heart failure, did they get the correct medications? It's now expanded to risk-adjusted mortality rates, risk-adjusted readmission rates, results of patient satisfaction surveys, and several other measures, and it's growing quite rapidly. Actually quite an easy system to use. You can type in a hospital or a location and it pops up that hospital and all the hospitals around it, so you can begin to compare. Don Berwick, who you know well, he's done a lot of tremendous work over here. In 2005, 2006, his organization, the IHI, launched a national campaign called the 100,000 Lives Campaign, and about 2/3 of American hospitals, about 3,000 hospitals, signed up to participate in this completely voluntary campaign. Peter Pronovost, whose work many of you know, and Mary Dixon Woods works closely with Peter and his group, in late 2006 published the results of their initial checklist study, which Mary has pointed out was not just about checklists, but also very much about leadership and culture change. By the way, if you haven't read Mary's article on understanding what really happened in Michigan, it's spectacular. I really commend it to you. But this was really an iconic case because Peter and Mary and their colleagues, really this was kind of proof of concept, the demonstration that a safety intervention could lead to spectacular decreases in rates of preventable harm, in this case, central line infections. Another issue that's very difficult to explain to lay people, when I explain to lay people that the main success story in the last 10 years in patient safety was we discovered that checklists are useful. They look at me like I'm crazy, but in fact, this, as we've all found out, that they can be, although the research we heard about earlier shows that it's not as simple as just putting in place a checklist, and I'll talk a little bit more about that in a few minutes. Here you see money flying out of a computer. The way we chose to try to promote information technology adoption was a little bit different than the way that was chosen here, and I think will be more successful. I know the system here did not work well. It was managed in quite a top-down way, and when I was here 2 years ago, I saw a headline saying basically the investment in IT implementation was being written off. The way this was done in the US was basically an incentive system using the private market. So in 2008, as we were passing a $700 billion stimulus package, they managed to slip in about $30 billion to promote the implementation of information technology. That system is rolling out now over the last year or two, and what it does is it pays doctors or hospitals if they implement computer systems that meet a set of standards that are called meaningful use standards. So really not, I think one of the things that was wise, it would not have worked in the States for this to be managed centrally. Instead, they decided to only manage it centrally insofar as to create a pool of money and a set of federal standards, but let hospitals and doctors' offices decide which system they wanted to implement. And so far, it seems to be working reasonably well. The rate of IT implementation has skyrocketed, both in doctors' offices and hospitals. And in October of last year, Medicare rolled out something called value-based purchasing, which is paying hospitals differentially based on their performance, quality, safety, and patient experience. Patient satisfaction surveys now leads to differential payment with bonuses or penalties of about 2 or 3% of your Medicare payments based on this program. When you add up the additional bonuses or penalties related to readmission rates, not being paid for some of these never events, about 5 to 7% of a hospital's payments for Medicare, the big federal payer, now hinge on performance. Up until 3 or 4 years ago, that percentage was 0. So now you see the imposition of the payment system on top of these other set of incentives to drive change. Okay, so I don't know about you, but I'm exhausted. That is a huge amount of change. And if you'd asked me in December of 1999, when the IOM report came out, how much change are we capable of promulgating and absorbing in 12 years, I would not have guessed this much. I think it's really an extraordinary amount of change, and I think actually quite impressive. And the things I want to point out to you are, you see now growing pressure on American hospitals and clinicians for safety, quality, and increasingly value, not just safety and quality and patient experience, but also increasingly cost. Importantly, coming from a lot of directions. The IHI campaign was all about social pressure. Medicare is now having all of our data publicly reported. The Joint Commission is a regulator, an accreditor. They're in the act. Payment policies are shifting. So it's coming at us from a lot of directions, and I think that has actually been useful. It's led to, in some ways, some flexibility in terms of the implementation of these policy changes, I think somewhat different than in a system where there is a single kind of owner of the system, the NHS, whose propensity is to adopt a more, I think, tend to adopt a more regulatory framework. And I think one of the things that's been exciting about this is in the early days when the Joint Commission changed their inspection policy or Medicare began reporting some of our data publicly, there was an inclination to treat these as single quality improvement projects. So when Liam came to visit, I think we were probably still in that mode of, okay, we need to aggressively figure out how not to leave surgical instruments behind. Let's do a project on that. when you're being hit from this many angles and the targets are this many different safety or quality targets, I think you begin to realize that you need to transform the way you've organized care, that you can't do this on a project-specific basis because you just quickly overwhelm. And I think that's where we are now in healthcare. And it's in American healthcare, it's actually an extraordinarily exciting stage where we're realizing we have to essentially redo everything, change the way we staff. As Leah mentioned, I helped sort of push this idea of called hospitalists, which are hospital-based generalists, a little bit like your acute physicians, although not just in AMU over the entire length of hospitalization. Now, fastest growing specialty in the history of American medicine. There are 40,000 of these doctors now, partly because we realized the old model wasn't working, and the system has turned out to be relatively nimble in coming up with this new model. How we communicate with each other, how we shift the culture, how we implement information technology, how data flows, how we look at the kind of data we see and are transparent about, both internally and externally. And I think in good systems, we've seen really very impressive engagement of clinicians in this work, something that I found, unfortunately, a little bit less of here than I saw in good systems in the States, certainly not universal. But that's, I think, where we are in the safety and quality field in the States, and I think there is something to be learned from our experience. Okay, that's the part I'll spend the most time on. The rest will be quicker. I want to talk briefly about what we've learned about motivation, which is sort of how do we motivate change, how do we make change happen and stick. I think Nick's presentation was really a little bit about that, learning simple intervention, checklists, of course, easy, but it turns out to be wildly harder than anybody would have thought because of this issue of engagement and motivation. So let me tell you the checklist story from an American point of view. And again, this is admittedly an American point of view. This is the way I see the way checklists sort of happen in healthcare. Peter Pronovost and his colleagues at Johns Hopkins developed this checklist for central line infections. What they did was they said, there's a bunch of evidence about if you do this thing, use large barrier precautions, that works. And if you clean the site a certain way, that works. And if you don't use the femoral site, that seems to work. And they and some colleagues said, well, it makes sense actually to bundle this together. So rather than trying to hit each of these 5 or 6 different techniques, let's call it a bundle and a set of activities. And then rapidly came on this idea of if I'm trying to remember to buy 5 things when I go to the supermarket, I use a checklist. What a great idea. Let's try to do it for that. They tried it at their own institution, Johns Hopkins, in 1 or 2 of their intensive care units. It worked. They actually tried to disseminate it through Johns Hopkins, and all of us had this experience of how difficult it is to scale something up at our own institution, because nobody believes us, because they know us too well. So he actually moved it to a different state and got essentially all the intensive care units in the state of Michigan to agree to participate in this work, and it was remarkably effective, lowering the rates of central line infections by 60 or 70%, saving thousands of lives, tens of millions of dollars, really a remarkably successful story. If the story had ended there, I don't think this would have taken off the way it did. What happened then was that Atul Gawande, and importantly, both Peter is a practicing clinician and Atul is a practicing clinician. There is this tradition in the States that I saw less of here, of practicing clinicians who are also accomplished researchers, and that ability to bridge the 2 worlds, I think, adds some real value. Atul wrote an article about Peter's work in The New Yorker. And this, of course, everybody read it, and Atul's a spectacular writer. It was a really exciting story, not just about the checklist, but about Peter and his work. And then Atul went on to write a book about this called The Checklist Manifesto. And Atul, working with a lot of colleagues, including colleagues here, extended this work to become the WHO surgical checklist. And it diffused through the US now, and so checklists are being used everywhere, and I think with reasonably good uptake, although we certainly have had some of the same problems that we heard about earlier. What I want to point out here, though, is this is, to my mind, a good example of a bottom-up innovation. This really began conceptually with a single clinician working in a local environment, seeing a problem, saying, this is terrible, we can prevent these very bad infections if we do the right thing, coming up with an idea, trying it locally, scaling it up, and then eventually scaling it at a federal level. It did not begin with a federal intervention or a large-scale intervention. Then I came here 2 years ago, and this is before hearing about the story and the study. I think when Nick and I met, you were just beginning or you were just starting to gather data about the study. And I was very excited to hear the results, which I think are fabulous. But of course, when it came here, because you do have a system and we don't, and as soon as people realize, okay, checklists sound like a good idea, the instinct and the inclination is to embed it in a federal policy and a rule. It's a natural thing to do. It's not like anybody's doing anything bad. If you were in control of a system and you said checklists unambiguously work, you would do the same thing. You would say, of course, let's make this a national mandate. It's a logical thing to do. And it, of course, became NPSA/2009/PSA 002/0U1. And we have this, the Veterans Administration system in the US has the same kind of flavor. It became a National Patient Safety Agency alert. And here it is, organizations are required to do this and account for it and make sure you sign off on it. All perfectly logical. As I think you said, most places said we were implementing it, but when you actually went under the hood, you realized they were implementing it with huge amounts of variation to be charitable. What I found when I was here is I talked to a lot of surgeons and anesthetists and nurses, and I asked them, how's the checklist thing going? And every single one of them said, another top-down mandate. That was their reaction to it. And I find it amusing in a way because it actually began life as a bottom-up innovation. But in its translation in your culture and structure, the instinct was to implement it in a top-down way, and you saw the results of that. There was pushback, lack of ownership. And I was sort of interested in you were presenting the results of the study. How much of the improvement was from the tweaking of what was on the checklist, making it a better checklist, and how much of it was just from the fact that these people now had some local say in what it looked like. My guess it's the latter, right? It's this local ownership issue. So I think there is a lesson there, and it's very difficult in your system where the inclination will always be to manage top-down, particularly in the face of these cataclysmic crises. It's logical that it would work that way, but how can the system learn from increasing evidence that it doesn't work very well? It's a very tricky thing to do. So the surprise here is this idea of a complex adaptive system, that healthcare is a complex adaptive system. This is the business writer Brenda Zimmerman who writes, the system and external environment are constantly changing. Uncertainty and paradox are inherent in the system. You cannot wish them away. The problems cannot be solved in a machine-like fashion. Sometimes can be moved forward that way, but you can't solve them in something that seems sort of logical. We're going to implement a checklist. It will work the way it looked like it would work on a PowerPoint slide. Individuals are independent but highly interdependent, creative decision makers who need to be respected and brought into the process. Solutions often emerge from minimal specifications and simple rules. Over-specification can get in the way. I think that's part of the lesson of the checklist work. Squandi makes that point in the checklist manifesto that by getting everybody to stop, introduce each other, and pause for a moment, it actually led to much better communication. And there was nothing on the checklist that said communicate better. But just starting everybody at the same point, in the same mental model, led to tremendous benefits. So I think this was a surprise to me, and I think one of the real lessons that we've learned in healthcare, and how we balance top-down and bottom-up, I think is one of our great challenges. I think in the US, when we blow it, it's not being top-down enough, because every now and then, it should be a rule. For example, cleaning your hands. You should clean your hands, and if you don't, you should be fired. Right? That should be top-down. It should be a mandate. After we figure out the education and the system, at some point you say, there is a rule, you must do this. So when we blow it, I think our disinclination to ever have a central rule and authority, and part of it comes from sort of our unique American ethos. We hated your government, so we revolted against you. Now we hate our own government. I don't know what we're going to do with that. But your inclination is, I think, the opposite. It tends to be more top-down because of the way you're structured, and I think partly the culture. The second insight that I think many of us have had comes from behavioral economics, and that really is that pay is a relatively poor motivator of change. And I think this is a tricky lesson to learn because, like top-down, it's logical. It's logical to say if we have a system that's not working well, if we just pay people to do it, it will work better. Here are a couple of the central books that have helped kind of describe this theory. I don't know how popular these were in the UK, but very popular in the US. Daniel Pink's Drive and Dan Ariely's Predictably Irrational. Ariely tells the story, which I think is just a wonderful example of a whole body of literature, of what he calls social versus market transactions. The story is of an Israeli daycare center. And what they found in this daycare center was the teachers all wanted to leave at 6 p.m. and the parents sometimes were late picking the kids up, and it caused all sorts of chaos when the parents were running late. And so, quite logically, they said, we have a great idea. What we're going to do is implement a fine. If the parents come late, for every 10 minutes they're late, they'll be fined, $5 or $10 for late pickups. Perfectly logical idea. The frequency of late pickups after implementing the fine went up. Why? Because they transformed what had been a social transaction where people felt guilty about keeping the teachers late and just sometimes they could not get out of work. They transformed it into a market transaction where people said, if I'm late, it costs me $10, but it's worth it because I'm stuck at work or I'm out to dinner with a friend. And that's exactly the way. And then they took away the fines and it did not go back to the baseline because once they had transformed it to the market transaction, it was very hard to untransform it back into a social interaction. I think a really very interesting insight from this field of behavioral economics. And Ariely wrote, when a social norm collides with a market norm, the social norm goes away for a long time. Money, as it turns out, is very often the most expensive way to motivate people. Social norms are not only cheaper, but often more effective as well. Now, that doesn't mean that pay performance is completely wrong-headed, but it does mean that we have to be thoughtful about it and be quite empirical about testing to be sure that it's having the effects that we hope. Here's the experience that we have had in the States with pay per performance. This is on the red graph here is the performance of all American hospitals on a set of quality measures that are now publicly reported. And you see they have improved markedly from 80% adherence to close to 95% simply with public reporting. And by the way, there is no real person in the United States who looks at these measures and chooses to go to hospital B instead of hospital A because of these public reports. It seems like what it's doing is much more internal sort of shame and pride. The blue curve here is hospitals that participated in a Medicare experiment where they not only were being publicly reported, but in addition, they had the opportunity to get bonus payments if they did well on these measures. And you see for the beginning year or two, yeah, it drives a little bit of incremental improvement, although fairly trivial. But by the end of 5 years, the difference is there's no difference between these two groups. So I think we have to be very thoughtful about the use of payment to try to motivate change and the possibility, as attractive as it might seem, the possibility that it will not only not work very well, but extinguish a lot of what drives healthcare providers, which is this social and ethical driver to do the right thing for their patients. So here I've shown sort of this 2x2 table of what I've just talked about. You can have extrinsic motivation and intrinsic motivation, top down and bottom up. And here the tire says I'm under a lot of pressure at work. When you're under a lot of pressure, so you're having a national crisis, as you're again having now, or the data are coming out showing that safety is not good, or whatever it is, the pressure to move toward extrinsic motivation, let's pay people more or cut their pay, and top-down management, let's have another rule. It's an understandable pressure, but I think the lesson is that that quadrant doesn't work very well. On the other hand, down here at the bottom, much slower, but I think ultimately more durable, is using both intrinsic motivation and a bottom-up strategy. And this makes it sound simplistic that you should be in one quadrant or the other. I think the key point is we need to be in the right quadrant for the right set of activities, and that each of our systems has a certain bias, the way it thinks, the way it tends to respond almost stereotypically to problems, that will drive it toward one quadrant or the other. And I think in the UK system, my sense is the driver tends to be certainly toward this top-down, maybe less on the extrinsic side. Okay, IT is harder than it looks. This is quick because I think you've all figured this one out. I think it's been surprising. I think we would have thought this would be easier. Certainly, my hospital just implemented a system called Epic, which is by far the market winner in the US. They are dominating implementation of most big systems. It is better than the ones I've seen, but as friends of mine have called it the cream of the crap. It's the best of a bunch of not too great systems. I think it feels like healthcare IT is getting worse because when I compare even my hospital's $250 million IT system to my iPad, this is so amazing how good this is. And healthcare IT still is so bad, even the best of the breed, which is I think what we have. I think the early glowing studies about how easy and good it was were not generalizable to vendor-built systems. They came from a number of places in the US that had built their own systems and were really quite atypical. We've seen unforeseen consequences, including a growing literature on IT-related safety hazards. That said, I think we have to computerize. It's just not going to work to try to do everything we have to do, including decision support, as we were talking about medication errors, with pieces of paper or cards and all that. It's the best we can do in some places, but we have to do better. I'm going to talk about a couple of unforeseen consequences of IT. This is one. Abraham Verghese is another very impressive physician, researcher, and in his case, a novelist, a beautiful writer. Wrote a book called Cutting for Stone a few years ago that was a national bestseller. Abraham is very much on the warpath about the impact of IT on doctor-patient engagement and relationship. And this is an article he wrote in the New England Journal 5 years ago that's very influential. Abraham wrote, "The patient is still at the center, but more as an icon for another entity clothed in binary garments, the eye patient. Often emergency room personnel have already scanned, tested, and diagnosed so that interns, that's our junior house officers, so that interns meet a fully formed eye patient long before they meet the real patient. The eye patient's blood counts and emanations are tracked and trended like a Dow Jones index, and pop-up flags remind caregivers to feed or bleed. Eye patients are handily discussed in what he called the bunker, the team's conference room, while the real patients keep the beds warm and ensure that the folders bearing their names stay alive on the computers." Besides being brilliant writing, I think that's just wonderful. I think that captures really a central concern, and I think it will be the next generation of concern. Once we all have computers, this is a natural problem that we are paying more attention to the computers than the people, and this was captured really poignantly in this. You may have seen this in JAMA last year. A 7-year-old girl went to visit her pediatrician. And I don't know if any of you are pediatricians, but sometimes these kids visit the pediatrician and draw a picture of their visit to the doctor, and it's charming and lovely. This one, though, the doctor I don't think put up on his corkboard in the office. She sent a cartoon, a crayon drawing of her visit to the pediatrician. There she is on the table, mom, sister playing with a baby doll off in the corner, and there in the other corner is the doctor with his back to the patient typing on the computer. There is no way that this girl or her mother can believe that this doctor cares about her or cares more about her than what's in the computer. And I think there are going to be human factors solutions to this. I think we need new design principles, but we also need to make sure people are educated to recognize that you're sending a message every time you sit like this when the patient is sitting there. And the more and more we computerize, the more we have to aggressively attack this problem. One more problem I want to address, and I do it sheepishly with Martin sitting here because I'm not an expert on aviation, but I do think there are things that I have learned from aviation, from people like Martin and others, that are very impressive. This is a remarkably computerized environment. This is the cockpit of an advanced Airbus, I forget which, maybe the A380, if I recall. And it's a miracle of computerization, an amazing amount of data inputs, and yet they have managed to figure out the human factors principles so that people are not overwhelmed by data. It tells them what they need to know when they know it. There's a saying, as you probably know now, there are 2 people in cockpits today. There used to be 3. And in the future, what I've heard in the aviation world is there may ultimately not be 2 people, but there'll be a pilot and a dog. The pilot's there to keep the dog company. The dog's there to bite the pilot if he tries to touch the controls. Now, that may be true and may turn out to be better and safer, and you can't argue with aviation safety record. The last death in a crash of a U.S. commercial airliner occurred about 5.5 years ago. That is staggering if you think about it. And yet there are still cautionary tales in aviation, and this is the one that I point to, the tragedy of Air France 447. Some of you may know this story. And again, Martin, I'm sure I'll botch this terribly, but as I have come to understand the story, this is a Airbus flying from Rio to Paris. And the plane went down a couple hours into flight, and for a couple of years they did not find the black box, and nobody knew what happened. And miraculously, 2 years after the crash, they found the black box and they dissected what was on it. And it told an unbelievable story. Basically, the story was there was the pilot, co-pilot were in the cockpit. The pilot at the time was a relatively junior pilot, fully qualified. The senior pilot was in the back sleeping because of their duty hours regulations, because they need to have a handoff during the flight because of the length of the flight. As they were flying through a storm, a little gizmo, that's what we lay people call those little things. Pitot tube, is that something like that? A little gizmo on the outside that measures airspeed froze. And all of a sudden, all of the data that came into the cockpit that is based on that airspeed monitor no longer worked. And they started getting information that was kind of wacky, or some of the computer modules just weren't even working because a lot of it required that airspeed as kind of a foundational data element. And so they're now in the dark, flying through this storm, and the computer is sort of going haywire, and it's signaling to them that they're stalling. It thinks that stall, 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 I think dozens and dozens of times. And this young pilot did what I would do if my plane was stalling, which is pull the nose up to try to fly higher. Makes perfect sense. It turns out to be wrong, right? It turns out the right thing to do when your plane is stalling, believe it or not, is to point the nose down so you pick up airspeed and come out of the stall. His instinct was the same as mine, but it was wrong. And as I've talked to friends of mine who are pilots, they think that part of what happened here, there were some design flaws in the way Airbus had built this cockpit, but one of the fundamental problems was that young pilots no longer really know how to fly the planes if the technology fails them. And a more senior pilot had been in that situation many times before because the technology in the old days was either not there or failed all the time, and they knew how to do it. So I think this is another thing that we have to think about as we increasingly computerize. We're going to train a cadre of doctors and nurses who no longer really know how to practice when the computer is giving them the wrong information or is not working, and I think we've got to be careful about that. Just a couple of words on the importance of culture. Here's one of the things that's been most interesting as a physician is thinking about culture as it pertains to us. A lot of you are social scientists and sort of study us as this sort of interesting tribe for a living. And I think actually we are kind of interesting in this regard because we are being forced to change our mental model about what we do for a living. Here's Atul Gawande, and Atul wrote this a couple of years ago. He wrote, "The core structure of medicine, how healthcare is organized and practiced, emerged in an era when doctors could hold all the key information patients needed in their heads and manage everything required themselves. We were craftsmen. We could set the fracture, spin the blood, plate the cultures, administer the antiserum. The nature of the knowledge lent itself to prizing autonomy, independence, and self-sufficiency, and to designing medicine accordingly." That sounds like my training in medical school or in residency. But you can't hold all the information in your head any longer, and you can't master all the skills. No one person can work up a patient's back pain, run the immunoassay, do the physical therapy, protocol the MRI, and direct the treatment of the unexpected cancer found in the spine. I don't even know what it means to protocol the MRI. This is the nature of the beast now. It is a team sport, and our mental model, which is it's all about us and we are the leaders and people take our orders, doesn't work anymore. And yet changing the culture of a profession is very difficult. And it's partly why we are so desperate for the insights of people who come at this field from psychology and sociology and others, and yet a lot of this has to be internal. It has to be the profession recognizing that even though the old model was reasonable at the time and perfectly noble, it's not working anymore. It's leading to safety and quality hazards. And so this is part of our challenge in changing the culture. Just one kind of surprise to me in safety culture, which I think has been quite useful for me as I think about this, comes from this study by Peter Pronovost and Brian Sexton from now 8 years ago. What they did was they were looking at safety climate, the results of surveys of doctors and nurses in 100 different hospitals in the US. And what they found was there was a pretty wide splay of safety climate, with some hospitals reporting a good safety climate in 40% of the time, others 80% of the time. So there are differences in hospitals in terms of how good the culture is. And this is things like, would you report an error if you saw it? Does the management care about safety? Those sort of things. So yes, there are differences in hospitals. But look at just this one hospital, Hospital X. You see it's a sort of mediocre climate on the lowish end of the curve here. About 50% of the doctors and nurses said they had a good safety climate. What they then did was broke down the results of those surveys to individual clinical units within Hospital X. This is just Hospital X. And what you see here is far more splay than you saw across hospitals. So one of these columns might be OBGYN, and another one is the emergency department, and another one is the intensive care unit. And you see here, some of the units had safety climates that were abysmal. 20 or 30% said it was good, others it was 100%. That's incredibly important because it says that St. Mary's doesn't have a safety climate, Imperial doesn't have a safety climate. Labor and delivery has a safety climate, and the med-surg unit 10 feet away probably has a different one. I think part of the reason that's so useful is I can tell you in the States when we say we have to improve, you might say, all right, how does the Mayo Clinic do it? How does the Cleveland Clinic do it? How does Johns Hopkins do it? And then you immediately say, yeah, but they're so different than we are. They are organized this way, or they've been doing this for 50 years. I think those lessons, and certainly if you say, well, how do they do it in the States? I mean, you get that on steroids. Whereas if you say, in our one trust or in our one building, there are places that really know how to do this and other places that are quite terrible at it. What can we learn from each other? You get rid of all of the noise of they're so different than us, their patients are different, the way we get paid is different. It's all the same, and yet the differences are vast. I think that's really been a very important epiphany for me. So let me end with this, sort of the dealing with change. This one I got from Don Berwick when I saw him speak a couple of years ago. I thought it was really a very nice example. We're being asked to change a lot. I mean, this is a tremendous amount of change for professions to absorb, to deal with, and it doesn't really matter whether you're a nurse or a doctor or a patient advocate or a manager or head of a trust or a policymaker. Our system has been found wanting, and we're being asked to do something very, very different. And it's troubling and challenging, and also, I hope for some of you, and all of you, really exciting, interesting, and important. This is the Choluteca Bridge in Honduras. It goes over a river in an area of Honduras that gets apparently huge storms, frequent hurricanes, many floods. And when they started to build this bridge, about 20 or so years ago, the country called the leading bridge design firm, apparently in the world, or maybe not quite the one here, but apparently an incredibly good design firm in Tokyo. And they said, this is a challenging job we got for you. It's got to be built to last in the middle of hurricanes and floods. And the design firm in Tokyo took this very seriously. And they put their best engineers on it, and they used their best materials and best computer models, and they built this bridge. And lo and behold, a few years after they built the bridge, along came Hurricane Mitch, and the bridge stood. There was not any problem with the bridge at all, and I can imagine the people in the design firm in Tokyo giving each other high fives, how wonderful it is that our bridge withstood this tremendous hurricane. There was only one little problem, and that was that the river moved. I think our healthcare systems have built really powerful bridges that were built to last, were built to stand up through all sorts of cataclysms. The problem is the river moved. And the new river is, how do we figure out a way to have a system and a culture and a workforce and tools that will deliver the best care at the lowest cost? And I really do believe that we can get there. I think that the work that you are doing here is immensely important in helping us learn how to get there, and I hope we'll all continue to learn from each other. Thank you for the opportunity to speak to you today.
Thank you, Bob. That was absolutely marvelous. And thank you so much for the kind remarks about us. We'll just take a couple of questions, then I'll ask David to close, and we're going to finish by 6:05 or just on. So just if there's something you want to say to Bob, you can talk to him over a drink, but if there's something you particularly like to say, please do so. Okay,
Nothing, please. That can't be that I haven't upset at least one person. Yeah.
And then, yes, you first, and then Bob first, yeah.
It was a wonderful talk.
Thank you.
Attention to all kinds of problems. But I was a bit worried about the climate change in contrasting hospitals as a whole with departments or whatever. Because the departments are smaller samples and you would get larger spread for that reason alone.
Yeah. So that's a very good point. There may be some statistical noise in that assay. I'm not a statistician. I find it hard to believe the noise is enough to explain 0% to 100%. But I think it's a very, obviously it's an important point that you have to look at the sampling, and the point estimates probably come more stable as you're looking at larger entities. I could tell you sort of empirically it feels right though, and I think often that becomes the test. It was one of those moments when I read that it helped me in the same way that the first time I read the work of Jim Reason and thought about the Swiss cheese model, I all of a sudden found and read some of Charles' work and read some of your work. I began looking at my workplace and I said, this explains so much. because I work in a fantastic hospital, one of the hospitals that's considered one of the best in the United States. And I said, wow, these people are really bright, really careful, really good people. They've got all the pedigree you can imagine, and we have errors constantly. And so seeing it through that system lens, all of a sudden I could explain the chaos that I saw. And this had the same flavor to me, that once I saw that, even if maybe the statistics are a little bit problematic, it felt very real. I go from unit to unit, and you see, even in one institution, some where people are enthusiastic about improvement. They want to make things better. The communication is good. People are willing to speak up to power. And you'll go to another unit in the same building, and none of that is true. And so I do think there's something useful in that, even if the statistics may be a problem. Thank you.
Thank you. One more.
Thank you for your talk. It's brilliant. I just wanted to make a comment on your point about checklists,
Yeah.
top-down versus bottom-up. So I've just recently been part of a project where we've adapted an endoscopy safety checklist to try and implement. And we thought we'd be quite clever and take the lessons from the WHO as well as Peter Proper's works. So I tried very kind of bottom-down. I went in with the nursing staff. I tried to gather ownership, and it still failed.
Yeah.
People still didn't like it. So I think it's interesting to look at those different perspectives, but what I did learn is you probably need an orange painted stick. So actually you do need the top down with a bit of beating. You have to do this, but give people the impression they're being incentivized.
Yeah, I think that's exactly right. It's important to say you can be successful and you can screw it up from both directions. I mean, I don't think there's any right way of doing any of this. And in fact, one of the right ways that I've learned is the acceptance of error, the acceptance that sometimes things will not work despite the best intentions, good people. And I forget whose quote that was, who gave that quote about learning all the ways that it didn't work. That is partly what yeah, there you go, about how organizations get better. So I think I think where you get into trouble is all of us have a bias about the right way of doing things and can get sort of quasi-religious about it. And that's everything from top down and bottom up to, I think every problem is a culture problem, or every problem can be fixed with an IT system. I think it's one of the real values of having teams of people, because they'll all have different religions. They'll come together and say, yeah, part of the solution is IT and part of the solution is culture here. That's what's so magnificent about Mary's work in describing the Michigan experiment, because the Michigan experiment was seen widely as checklists. They work, it's easy. And then when you go in, it was yes, checklist. It was leadership engagement. I forget where Mary's sitting. Where are you? This hard edge or something. There was this term you used about how the leadership were given cause to feel a little bit uncomfortable if they were doing badly when compared to their colleagues. There was bottom-up engagement. It was everything. I don't know if you want to comment. I'm sort of paraphrasing your work and probably getting it wrong. Okay, but I think that. There's never going to be one right way to do it, and I hope the key is that you're not discouraged from that. You learn from that experience and try it again with a slightly different way, and also to not take away the lesson that that was exactly wrong, because probably if you did exactly that way with another unit, it would have worked beautifully. Good, thank you so much.